All right, greetings and welcome to Global Perspectives on Surgical Simulation. This program is an initiative of the American Academy of Otolaryngology Head and Neck Surgery Foundation's Humanitarian Efforts Committee. Surgical simulation has become an increasingly hot topic of interest in surgical education, with our academy and its members leading out in both surgical simulation events and boot camps throughout our country. There are a lot of advantages of surgical simulation over passing the burden of learning onto our patients in terms of risk and morbidity. And the ideal simulation, of course, is low cost and high fidelity. The classic simulation that we've used for many years is cadaver dissection. And this is terrific in terms of its fidelity. However, it's high cost and not always available. Therefore, our members and their collaborators around the world have come together to put together low cost, high fidelity simulations that we hope that you'll be able to adopt and adapt to your surgical needs and your education of your trainees. We have 3 simulations we're going to share with you today, and these will be followed by a discussion of these. Our first simulation will be an ear tube simulation, followed by an airway simulation, a thyroid ultrasound simulation, and a wrap-up discussion. My name is Christopher Church, and I'm from Loma Linda University, and I will serve as your moderator today. Our first presentation will be an ear tube simulation by Dr. Gregory Basura and Dr. Appiah-Thompson. Dr. Basura is a distinguished neurotology specialist at the University of Michigan. His research interests include auditory cortex plasticity, central auditory neuroanatomy, and neurophysiology. Dr. Basura serves as the current chair of the Otolaryngology Humanitarian Efforts Committee and is a driving force behind this webinar. He is joined by Dr. Peter Appiah-Thompson, who is an otolaryngologist. He is a recent graduate of the University of Cape Town Otology Fellowship. Welcome, Dr. Basura and Dr. Appiah-Thompson.
Hello, my name is Greg Basura. I'm a neurotologist from the University of Michigan, and today I'm joined by my colleague, Dr. Appiah-Thompson from Cape Coast, Ghana. Today we're going to talk to you about surgical simulation, and specifically we're going to instruct you on building and using a very low-cost ear tube simulator model. So my colleague here from Ghana, Dr. Appiah-Thompson, is going to show us how we would build one of these that can be used pretty much anywhere in the world, that can provide a near realistic replica of what you would see with an ear canal and a tympanic membrane that you can use to not only teach yourself to practice with ear tubes, but also as you're teaching residents or trainees. So Dr. Appiah-Thompson, we've got a typical latex rubber glove that we've cut the finger off of. And he's going to take that glove and stretch it over what we've taken here as a typical 10 cc syringe that we've cut in half. So this is going to serve as our ear canal, and he's holding the eventual replaceable tympanic membrane. So I'll let you deploy that. So obviously to simulate the eardrum, you've got to pull it pretty taut so it's tight. And I'm going to help him secure that down with maybe a piece of tape. So as he's pulling that tight to simulate this, we're going to tape secure it along the outside of the syringe like this. Excellent. So you can show us what we've got here. So now you've got a nice, simple ear canal and a drum. So now he's going to mount that into some kind of a dish so that this can be used under the microscope to practice. So once it's tight, you can then come in with your binocular microscope. And you can see now he's looking straight down what would be the replicated ear canal and the tympanic membrane. So at this point, he'll focus just like he normally would with his binocular microscope and place the tube. So now, using a straight pick or a myringotomy blade, he can make a standard incision that you think would be a radial-based incision. And this can be accompanied by any regular ear tube. It can be a T-tube, a collar button tube, a Titan, any tube you have available that you want to practice. You can practice nicely with any of these varieties of ear tubes. Get it the upside down there. So there you seated the ear tube. It's you may want to move your light around a little bit so that you can see the. You may want to look at the. Can you move your scope just to get a little better view there? Potentially. Okay. It's a little bright, but you can see that the ear tube is in place. And at this point, he's completed the tube. Now at this point, he can put in several tubes there. There's enough room to make multiple incisions. And then to repractice, he simply just has to replace the tympanic membrane with a new finger from the glove. So Peter, what are your thoughts on this simulator model and its application to your practice and your training? Do you feel like this is a realistic thing that you could use that will help expand your skills?
Yes, very, very simple. All you need is the syringe. You cut it, you cut a piece of glove, slide it over it, and you have a tympanic membrane to work with. And you can do as many as possible to make your skills better. And I think it's a great tool.
Right.
Yeah.
Do you think that when you go back to Ghana and you're involved with teaching residents and medical students, trainees, do you think this will be something that is accurate enough that will provide good simulation for an eventual ear tube?
Yes.
That you would want to use this, or you could use this?
Yes, very much so. It's a very simple tool. Anybody can just make it up, and so I think it's I'm going to use it so much. As many students, as many residents as possible are going to have the opportunity to learn to put in tubes, and it's very, very good. I think. Did you come up with it by yourself? This is great.
I'm not exactly sure where it came up with, but this was one thing that we thought about over the years that was very straightforward. We used this in Ghana previously in Kumasi.
Oh, interesting.
And realized that we needed something that was, first of all, inexpensive,
yeah,
that could be immediately applied, but then you can use it over and over and over again. That's realistic. That's the other important part of this, is it needs to be realistic.
Yes.
That you're actually utilizing the technique that's going to help you when you're actually performing the procedure.
Yeah.
Yeah. So it's great. Well, thank you for showing us how easy it is to put a tube in. And thank you for your time today, and we look forward to providing you with further webinars about other surgical simulation techniques. Thank you very much.
Our next simulation is an airway simulation. This is going to be presented by Dr. Brianne Roby. Dr. Roby is a pediatric otolaryngologist at Children's Minnesota and an associate professor in otolaryngology, head and neck surgery at the University of Minnesota. She is the fellowship director for pediatric otolaryngology and also the director of the cleft lip and palate program at Children's Minnesota. Dr. Roby is joined by Dr. Shazia, who is an associate professor in the Division of Otolaryngology at the University of Cape Town and is the head of pediatric otolaryngology services at the Red Cross War Memorial Children's Hospital in Cape Town, South Africa. Dr. Peer is the program director of the first Pediatric Otolaryngology Fellowship in Sub-Saharan Africa. Dr. Roby and Dr. Peer are joined by Dr. David Zopf, who is an assistant professor of pediatric otolaryngology as well as an affiliate professor of biomedical engineering at the University of Michigan. Welcome, doctors.
Hello, everyone. My name is Brianne Roby, and I am a pediatric otolaryngologist at Children's of Minnesota. Today, we are here to discuss virtual simulation for global education, and I am joined by my colleagues, Dr. David Zopf and Dr. Shazia, and I will have them introduce themselves to you all.
Shazia, go ahead.
You're too kind, David. Thank you. I'm Shazia. I am a pediatric otolaryngologist out of Red Cross Children's Hospital and the University of Cape Town, based in Cape Town. And it's lovely to be with you today.
I'm Dave Zopf. I'm a pediatric otolaryngologist at University of Michigan and excited to join this group.
So I'm going to actually show you. This is one of the 3D printed ribs that I got from Dr. Zopf. And as you guys can see, I just have an 11 blade right here, but the texture very much feels like rib. And so you get that tactile feedback. You can help, when you're teaching, it feels very real. And this, I think, is a great tool. And you can also see how real life it looks. And so while I have the initial model, I'm going to turn this over to Dr. Shazia to maybe show us, once you've carved your graft from this great rib model, how you can use it to learn more about laryngotracheal reconstruction.
Yeah, so thanks, Brianne. I mean, Dave's given me one of these, I would like to say, more than 5 years ago. And I must say they're fantastic. And I'm going to just bring it down just to show you. Can you guys see that on your screens?
Great.
Looks great.
Yeah, so one of the things that I found was very hard to teach was, the laryngotracheoplasty, because you're here, you're with a patient, and the last thing you want is for someone to learn, on a child. So this really shows it quite effectively. I've made the incision already, and I'm coming through to the other side. And what's really nice is on these models, you're able to show a trainee just how to go through and how to make that incision relevant to your graft. So, the graft always has a flange, and this is explained so well once you make the graft. And I actually put that down, and that would actually go in. I think we're gonna have to just go through onto this side. Is this okay, Brianne?
Absolutely. Yeah, keep going. This is a great education, and I think it really shows the utility of where I started with the rib model that I used to carve, and how you've taken that model and are now using the 3D model of the airway and how to teach this.
So what I like about these models is that once a trainee or a fellow has completed it, they can take it on with them, they can undo it and redo it again. But also it allows us to let them do a few as they progress through the year. And so they're able to see just how well they've moved along, and also just how independent they are once they've already passed the skill on. I think what I find to be the best is that they're not practicing on patients. I used to, and I still continue having, a pediatric airway dissection course on PEGs. And even though it's wonderful and it's similar to, the age group that we use to train people on, you can't take the pig dissection home and have a look at what you've done. You have to actually discard that ethically and safely. But this you can sit on your kitchen table and go through over and over again. That's what I really like about it.
And Shazia earlier when we were discussing made a really excellent point in that just being able to archive and hold on to like some of the completed simulators as kind of an educational resource and a resource for patients and families to refer back to and use in discussions for consent and counseling, I think is a really awesome point.
Absolutely. And I think one other thing to kind of add to that is that with these kind of simulation, you don't always have to be in person. We've started a virtual simulation course for pediatric otolaryngology fellows that we're now expanding to both international for global education and now facial plastics fellows. And this is a course that started in person. And during COVID, we had to transition into virtual. And I think that is going to allow that education to expand further with the use of simulation, because you can teach just the way, at our course. Dave, maybe explain how we set that up for the learners there.
Yeah, so I think it's been exciting kind of see it expand year over year. Really the trickiest thing as we've kind of expanded that fellowship course has been finding the sweet spot in time zones just with the international. We don't want, our colleagues in the more Eastern time zones to have to stay up too late and don't want to ask our West Coast US colleagues to have to wake up too early. So, but it's been really exciting kind of having everybody participate in this really intensive and enriched educational experience concurrently from all parts of the globe.
What was really nice, if I can add to that, is one of my former fellows, she's now in Namibia, she said, oh my gosh, we do it the same way. And I thought they would have never known that if they weren't in the same room, the same virtual room. And she said, oh my gosh, we do it the same way. And I thought that was so cute. And I was like, yes, of course we do it the same way. But it was because she'd seen so many North Americans and so many other people doing exactly what she was doing when she was doing open airway, because she's now post-fellowship and she's in Namibia. And it was actually, for me, it was really nice to hear that, because they felt a sense of accomplishment having finished a fellowship program that's, teaching the same that they're learning, and they're able to see it. And they would have never had that opportunity, to see what was, in North America in such a, 2-hour space.
Yeah. Shazia, let's see that work. That looks great.
Yeah, and I want to just show if there's, just opportunity. This is the back rib that's harvested that you could do a front and a back, and you could even use an endotracheal tube as a stent if you really wanted to. And then I would just, obviously parachute the entire thing down and tie it up. And you can see that this part, as a trainee, when I was training to do this, it's quite tricky to explain to someone that you want the flush of the flange, with the tissue. And this does it very well, especially the fact that, there are 2 different colors and it looks pretty much like a rib there. So that's kind of cool. I love the way this looks, actually, David. It makes it so much easier to imagine, even for the parents.
That's great. Well, we're going to, as we wrap up, any final thoughts on the benefits of 3D models, simulation? Shazia, I think you said some of the best thoughts I've heard, so let's hear from you.
Well, thank you, Brianne. What I do want to say is that the resources in South Africa, and certainly in Africa, always hard to come by when we're looking at real cadavers and even pigs and things like that. So this comes at a great time when we want to look at cost saving, but also effective training. And I can't imagine a better way to have a panel talk about airway reconstruction, and then an hour later, have tea and move to a table where we all sit around and have these, and in the same light, share it on a Saturday afternoon across the different continents, because it sort of puts the memory in that table onto a virtual platform on a table. So this is wonderful for me. Thank you.
And Dave, any final thoughts from you?
Yeah, so many great discussion points we've had. There is an airway surgeon in India, E.V. Raman, and we had put on helped put on a course in India where they utilized some of the 3D printed models and not having to use animal tissues. I later saw Dr. Raman at a meeting in San Diego, a Centec meeting in San Diego, and he came up and said, I really don't know how, if you realize how impactful that is for our trainees from a cultural standpoint to not have to use animal tissues for education. And he said their group would forever be indebted. And I was really kind of just taken aback on how, important some of those considerations that I hadn't really thought of can play. So it's been really exciting to kind of see the simulation and the value that I think it can have.
Great. Well, I want to thank everyone for joining us for the webinar today. I think you can see that there's a lot of passion about simulation and global education, and I think to me we're just touching the surface right now. I think this is going to be more to come as we go forward. But I really want to thank you both, Dave and Shazia, for joining us today for this webinar.
Our third and final simulation presentation will be a thyroid ultrasound simulation. This will be presented by Dr. Mary Sebelik. Dr. Sebelik is an endocrine head and neck surgeon and professor at Emory University in Atlanta, Georgia, USA. She is a head and neck ultrasound educator and champion. Dr. Sebelik is joined by Dr. Maria Karen Alcantara Capuz, who serves as the program director in training in the Department of Otorhinolaryngology Head and Neck Surgery at East Avenue Medical Center in the Philippines. She is an assistant professor at the University of Santo Tomas, Faculty of Medicine and Surgery, Department of Otorhinolaryngology, located in Manila, Philippines. They are joined by Dr. Geraldine Luna, who is an active consultant with the Asian Hospital and Medical Center, Philippines, where she serves as the unit head of the Head and Neck Interventional Ultrasound Unit, Department of Otolaryngology Head and Neck Surgery. Dr. Luna's focus of practice includes thyroid and parathyroid diseases and surgery. Welcome, doctors.
Hello, I'm Mary Sebelik, and I am delighted to join my friends, Drs. Capuz and Luna, who are fellow ultrasound champion educators. We are going to discuss low-cost phantoms for neck ultrasound education. I am going to describe a method to time ultrasound-guided FNA. It is shown that from the progression from novice to expert demonstrates a reduction in time to completion of placement of a needle accurately to a target with ultrasound guidance. What we have created is a homemade device that allows exact timing of the transit of the needle placement into a phantom to a target with accuracy. And this helps further demonstrate that novices turn into experts with repetition. This is a little video demonstrating that you can use this timer in any kind of ultrasound phantom. This happens to be ballistic gel. The timer is started and the needle is placed under ultrasound guidance. The timer stops at exactly the moment that the needle hits the object. Well, how did we create this? We made a circuit board that is placed within a 3D printed box. It has a power source. It has an output that goes to the ultrasound guided FNA needle. It has a metallic object that's inserted into a food product. This food that works very well is a hollow olive. You take the pimento out and you put the metal object within the olive. Then that olive can be embedded within any kind of ultrasound phantom, whether that's food such as this chicken breast, ballistic gel, food-grade gelatin. This object shows up very nicely under ultrasound. This is just showing the completion of the Phantom by embedding 2 different objects within chicken breast. It is tightly wrapped, and I will show in the next slide it is quite faithful in its ultrasound characteristics. So this is a video demonstration of using this Phantom. First, the object is detected, and you can see this circular object that has some isoechoic material around it. The timer is started, and the learner inserts the needle with ultrasound guidance, and the approach to the object is shown in the ultrasound. And then once the target is achieved, then the timer stops, and it looks like this took 8.51 seconds. I'd like to thank my son, Will Sebelik, who is a biomedical engineering student, for the ability to create this homemade, low-cost, ultrasound-guided FNA timer. And I'm very delighted to be involved in this webinar. Thank you.
Good day, everyone. I am Dr. Nisha Caleda, a resident of the Department of Otolaryngology, Head and Neck Surgery of Asian Hospital and Medical Center in Metro Manila, Philippines. Together with my mentors, Dr. Geraldine Luna, Dr. Alvin Tapia, and my co-resident, Dr. Bianca Dizon, we developed a low-cost Phantom model as a learning tool for acoustic impedance in ultrasonography. We understand that before one will commence their ultrasound journey, the people should first and foremost be familiar with the physics of ultrasound. Acoustic impedance is one of these concepts that form the basis of medical ultrasound. The images achieved during sonographic studies rely on reflected sound measurements. If sound waves flow unimpeded through the tissues, there would be no reflected waves to measure. Sound wave reflection occurs at interfaces between materials with different acoustic properties. In one of our reference studies, the use of gelatin phantom can serve as an excellent alternative to commercial phantoms for practicing and teaching ultrasound and ultrasound fine needle aspiration. In this model, we used a low-cost, locally made gelatin powder and made a ratio of 1 ounce gelatin powder to 3 3/5 cup of water. We incorporated several common sundries, nata de coco, which is a local hard gelatin delicacy usually packaged in a bottle, frozen chocolate with nuts, gelatin-filled capsule vitamins, olives, a slice of banana, and peppercorns, nearly all of which can be acquired in a nearby supermarket. During our sonographic studies, we used a low-cost portable ultrasound machine, and we were able to elicit different echogenicities and simulated tumors and some features of tumors, such as cystic lesions, isoechoic, hypoechoic, and hyperechoic images, micro and macro classifications. Please note that nata de coco created a hypoechoic image due to its lesser density with the gelatin material. The frozen Ferrero chocolate created classifications and posterior acoustic shadowing due to it having a different density and acoustic properties compared to adjacent structures. The peppercorn as well created the posterior acoustic shadowing. The olive, on the other hand, created a hyperechoic ring and a well-delineated structure due to its somewhat similar density to the base material. This can be correlated with some benign tumors. As for the fluid-filled vitamin capsule, the image created a cystic lesion within the parenchyma of the gelatin model. Here we can teach the student on how different substance densities can create a unique image in the ultrasound machine, and why some images would look like incomplete images due to the inability of the sound waves to be reflected back due to significant acoustic impedance and velocity of sound waves in each substance. In using phantom models, it is important to use low-cost, reproducible, reusable, and biodegradable materials. Thank you.
Step into the world of innovative medical education with our low-cost ultrasound phantom model for ethanol ablation of a cystic nodule. We start with a chicken breast, which offers a realistic texture for ultrasound practice. A slit is then created on one side of the chicken breast for the placement of our cyst. For the cyst contents, a simple concoction of the following ingredients is mixed together to mimic colloidal cyst contents. The mixture is then placed inside a cut glove finger, which is knotted in one end and further wrapped in transparent tape to help retain the fluid contents in the cyst once it's aspirated and refilled. Carefully tucked inside the chicken breast, our phantom cyst model comes to life, ready for learners to explore and master the skill of ethanol ablation of a cystic nodule. Through this low-cost phantom model, learners can practice visualizing the lesion of interest, plan the needle entry approach, and gain invaluable simulated experience of ethanol ablation in a safe and controlled environment. Thank you for joining us on this journey of discovery and learning. Together, we're shaping the future of healthcare, one simulation at a time.
Thank you for those wonderful presentations. We're excited now to have with us the leaders of each of those presentations, Dr. Basura, Dr. Sebelik, and Dr. Roby. And we're going to have a discussion of how we came to develop these different simulations and kind of how they're being utilized in each of our practices. And I'll take them in the order that they were presented, and we'll start with Dr. Basura. So tell us a little bit about how that ear tube simulation came about. Is that something that you came up with, or was that something you've adopted from elsewhere? And then tell us a little bit about how you're using that in your training.
Well, great. Thanks, Chris. And appreciate the opportunity to speak on this panel. Just to underscore the importance of surgical simulation, particularly in low middle income countries. The genesis of this really came out in a lot of the work I've been doing in Africa. And as you mentioned earlier, a lot of the things we're doing in Africa require temporal bones. And in some places, they may be more plentiful than others. And with temporal bones, you only have so many opportunities to work on certain structures like the eardrum, for example, because if you're making incisions in the eardrum, over time, that's rate limiting practice. And so you have only a certain number of practices before you can actually no longer use that. And so as this has evolved for me over the last decade in Africa and work in Ghana and now in Cape Town, it just started to think about how can we simulate an ear canal, how can we simulate an eardrum, so that we can create something very simply, very cheap, that we can use over and over and over again to modify or to optimize practice. And so I just started to think about things that we had around the hospital, things that were in the lab, and you think about what an ear canal and an eardrum were. And we just kind of came up with the idea, if you have a large enough syringe, you can cut the tip of the syringe off. It really will simulate nicely the natural caliber of the human ear canal. And that usually can be like a 5 to 10 cc syringe. And then if you think about the eardrum being this very flexible, pliable material, you think, well, what can we put over that? Well, we use latex gloves every day in our practices. So just simply cutting a finger off of the glove and then draping it over the end of a cut syringe, it seemed to make a lot of sense. And so it was just something that we actually thought about, and we just built sort of on the fly, really, so to speak, in Ghana in our temporal bone lab that we started there for them. And yeah, there's limitations to it. The drum and the rubber glove is not quite the same. But what it does is it gives them the dexterity of working down a very narrowed space like the ear canal with micro instruments, making incisions, and then practicing the actual movements that are required. So it's been a great success. It's very cheap. It's easily to reproduce anywhere. It can be mounted on a temporal bone holder, and so you can use it under a microscope in the lab. And so it's very versatile. So I've been using it in the practice here with the residents here, even at the University of Michigan, because again, for practice sake, it can be applied anywhere. It doesn't matter the level of development of the country. I think the utility of it is universal. And so far, it's been, the feedback from the trainees has been really favorable. So I'm really excited about it. It's very simple. And of course, always looking for ways to modify it going forward.
So, Dr. Basura, so what, as you developed this, what kind of challenges did you find with assembling this that you didn't anticipate in terms of maybe technical challenges of holding the syringe steady? I noticed that you used a temporal bone bowl holder. What if I didn't have that? What are some of the things that you had to modify as you created this?
Yeah, fortunately we have had those there, but in situations, we've encountered little challenge with it because it's so simple, it's so straightforward. You could have simply somebody hold it. Somebody could hold that. You could have a third party or a second party, somebody actually holding that for you, serving as the holder. Most places have some kind of, maybe like a vise or something, or even like almost like a large forceps that you can clip and hold. So even if you don't have a temporal bone holder, you could do this. Some people, if they have loops, something that would magnify, they can still do this. And if they didn't have a holder, they could have somebody actually hold it for them. So honestly, I really haven't had any major challenges with it. I think the biggest challenge again is the haptics of the glove, and how does that relate to the drum? Because many times it's rubber and it's moving. There's it's not the exact type of tissue that we have in the drum. And so there's always ways to think about it. There are other things we can utilize there. I was recently at a temporal bone course in Zimbabwe where they use the same simulator with endoscopic work. So people were using endoscopic work with this. And so it's actually, it's had a lot of wide application with, I think relatively, the beauty of it is so simple that it poses really actually limited challenge in terms of building it and using it.
And what have you seen in terms of watching your students as is it facilitating the transition to actual, tympanostomy and tube placement, or is that, I know that's something that's probably hard to quantify, but you've been teaching for a long time. So what do you see?
Yeah, I think, most of the feedback so far from my African colleagues has been positive, that it's providing them confidence now. I think the biggest issue is the ability to feel comfortable with repetition. So in the States, I think obviously by the time I see them, oftentimes in the otology, they've been on PEDS, they've had other experiences. And so they've had a lot of opportunities in the OR on actual patients. So I haven't had as much feedback from residents here at my institution, but from my African colleagues, it's been positive. Because people now, with repetition comes confidence, and they feel more comfortable with the actual human ear when they're posed with an ear to put a tube in. Yeah. So it will be something. It'd be nice to, and Mary and Bree may have similar thoughts on this. Is how can we quantify the efficacy of surgical simulation and its impact? And that's something we need to think about as we go forward. Is how can you really gauge the impact these simulations are having in surgical practices around the world? And so I hope that that's something that we'll continue to explore in a more, measured way.
Yeah. And Dr. Roby and Dr. Sebelik, I know you guys have been leaders in simulation training. What do you do in your boot camps and your programs to try to quantify and measure how this is working?
Yeah, that's a great question. I will say we've done it more on every year since, since 2019, we started in person. And then since 2021, we've done a virtual simulation boot camp for all of the pediatric fellowship fellows around the country. And we have been able to do measurements based on surveys. It's not an objective measurement, right? It's a subjective measurement in what they're saying, their comfort level before and after, and then kind of doing follow-up surveys with their fellowship directors. Do these fellows seem more confident having done the boot camp than prior to the boot camp fellows? And so we're getting some subjective feedback on that, which is a great start. I think looking for objective measures is definitely the future. I think it's where we need to go, but the subjective stuff is being looked at now.
That is a great question. And that is, we were in simulation, we're able to get two ratings. One is the reality or the feel or the opinion of the simulator. And then also of the learner, do they feel more confident after using the simulator to practice a new skill? So those are the first half, right? Are the simulators good, and is there an achievement of confidence? But the back end is, do you get better and better the more you use this simulator? And then most importantly, can you incorporate it into practice and do good patient care? So, and I agree with Dr. Roby that that's being studied in many ways for the practice of point of care head and neck ultrasound. It's a slow process. It's not going as fast as I would like to see, but there are some really wonderful experts around the world who are creating OSCEs, who are creating global performance metrics, getting objective data like one of our simulators we're talking about looks at time to completion. All of these are the middle part of this science. Confidence and opinion of the simulator first, the science of achieving metrics that it's actually working, and then the back end, does it result in better patient care? And I think we're well along the road to that in thyroid, in head and neck ultrasound, but boy, it's a slow process.
Yes, indeed. Dr. Basura, I will kind of echo what you said about, even though your particular simulation has some haptic limitations compared to the actual thing. There's so much about learning to visualize through the microscope, or I'm a rhinologist, so learning to get good visualization with an endoscope or that sort of thing. And it doesn't actually necessarily need to be as high fidelity as the actual human body is in order to be educational. By the time you've learned how to drive the scope or the microscope or see that, it's just going to make it that much easier when you get there to actually do the task. So I think your simulation is an excellent way to develop those skills. Dr. Roby, tell us a little bit about how you guys have developed your airway simulation.
Yeah, well, thanks for asking. This is why I asked Dr. Zopf to join me in our video, because he's really been at the forefront at the University of Michigan. He works and has a lab actually that does 3D printing for simulation. And again, kind of going back to how we first started doing this is we had done some simulation boot camps and prior to the pandemic, and in 2021, we did our first virtual simulation boot camp. And what this entails is everyone who's been part of the boot camp, they get mailed a kit. And in that kit, there are 3D printed models. And we picked, for the pediatric otolaryngology fellows, we picked 4 different types of cases that are challenging cases. They're very technically difficult, but at different institutions, they're not always frequently done. So the one we focused on for this simulation was the laryngotracheal reconstruction simulation. But in the boot camp that we do, we also do a cleft lip and cleft palate model, and then a microtia rib ear carving model. And this is just, again, to help the participants get some early feedback and skills that they have going into their fellowship year. we ended up last year expanding it. Once we had success with doing it virtually, this boot camp virtually, and we had found that it was easy to set up virtually. We reached out to some of our colleagues globally, and Dr. Shazia has a long standing relationship with many of the pediatric otolaryngologists here in the United States, and also has her fellowship, the first fellowship in the sub-Saharan Africa. And so it worked out great that not only did she join us as an instructor, which I think is really important to highlight because she was an instructor, not a participant, but she had all her former fellows and her current fellows participate with us. And so they all got the 3D models mailed to them, and those models are very lifelike. It really does feel like you're working with real cartilage for carving the laryngotracheal reconstruction. You get both the rib model to carve the rib, and then you get the airway model to place the grafts into the trachea. And basically, the participants have cameras set on their hands. We send them like a little phone holder, and they can set that, and they can work with partners as well and focus in on the skills. And then we usually have 2 instructors in each boot camp simulation room, and one instructor is actually taking people through step by step, and the other person's role is to watch everyone and kind of give feedback as we're going, to give them tips and ideas to better help their skills. And so that model has worked really nicely because people are getting feedback in the moment, real time, with models that feel very real. Dr. Peer, in our video, one of the things I want to highlight with that model is that she really emphasized in there that one of the benefits is the fellows get to take those models home. And they then can take out the grafts that they placed, the rib grafts, and they can do it over and over again. And so since each airway surgery, open airway surgery, is different, they can, discuss or be thinking about planning what do they think this patient needs, and they can practice whether they need both an anterior and posterior graft, whether they just need an anterior graft, different sizes and shapes. And they can keep practicing over and over again with these models once they've had that first opportunity to practice. And so I think that's one of the beauties of this simulation is that, with a cadaver, you can do it once. You're in a cadaver lab, you get to do the procedure once. But with these 3D model simulators, you can just practice over and over again, which is one of the things that Dr. Basura mentioned with, the low cost of the model that he uses. You can do it over and over again and not feel like you're wasting some precious entity. I think that's the benefit of it.
Mm-hmm. And for those of us who are not as familiar with the 3D printing, tell us a little bit about, how are these models created, and are they accessible to anyone, or do you have to own the technology to create this?
Yeah, that's a great question. So in the sense that, like, I have a 3D model printer at home that my kids play with. We can't just start printing my crochet ears. Like, it doesn't have that type of technology. I think that's in the future. The way that it's been set up, and I give a lot of credit to Dr. Zopf, who's been at the kind of at the forefront of this. But number one, anyone could reach out to him and see if they can get the models printed by Dr. Zopf. No, they've done their lab prints a lot of different 3D models, both in head and neck and some other areas as well. But you can reach out, and they've done things with laryngeal cleft and ears. The other thing that they have worked with is developing the models that, for instance, if you are at a university in Cape Town that does have a 3D model, and some universities around the world do have it, they can send the model and the template to that 3D printer. And so the way I think about this is going to expand on both fronts, both people getting word of mouth that they can reach out to some of these labs that are printing these models. And it's obviously cheaper to do it when these places are printing a lot of them. And so I think from a cost standpoint, the more this expands, the cheaper it gets. There is some funding for a lot of global opportunities if they reach out and want 3D printed models. The lab, at least that Dr. Zopf runs, is working with them to try to make it economical. And then I think long term, what's going to happen is as 3D printing becomes more and more global, I think that places will reach out and just ask for the template. So you don't start the wheel over and over again, and you just reach out to the places that have them templates and ask for that copy.
Excellent. Dr. Sebelik or Dr. Basura, have you guys had experience with 3D printed models?
Yeah, I'm glad to chime in right here because that's that. So thank you, Dr. Zopf, for being a professional biomedical engineer as well as a surgeon. My son is a biomedical engineering student, and unfortunately, or fortunately for him, he has been forced into helping me teach ultrasound globally for much of his life. So he has in his DNA the desire to create some kind of support for surgical education that is widely accessible and free. So his strong ethic on this is that once you create a 3D printed model that can support a simulation, that it should be absolutely open access, and that the STL files can be open access, free, available, and can be loaded into this is important, a consumer grade, or the 3D printer, Dr. Roby, that you have, a consumer grade 3D printer and not a fancy engineering lab. And that's he's been a great collaborator for that, because basically, like Dr. Roby, my basement is our simulation creator 3D printing lab. And so, I mean, it can be done at low cost, but it's more important that it can be done at low cost elsewhere. So those STL files, the 3D printing templates, need to be available for sharing. And I just think that's how we disseminate this more and more quickly. So I'm glad to hear you also have your own personal 3D printing lab, Dr. Roby.
Yes.
Well, first of all, congratulations on raising a son who has those kind of values and gifts. I think we could use more excellent biomedical engineers in this field. Dr. Basura, have you had any experience dealing with 3D printed models?
Yeah, I certainly have. And the temporal bone that's become more of a centerpiece now to 3D printed temporal bones for surgical simulation in areas where, actual temporal bones may not be so readily available. That's becoming more of a mainstream option. There's limitations to it. So, but the point I think, and Mary and Bree bring this up nicely, is that this will be kind of more the future of simulation, I think, going forward. I think it'll continue to be refined. And I think as it gets more refined, it's more available, the cost will be lower. And so I think this will be an instrumental part, kind of like at the core of surgical simulation going forward, which will be really nice. I think it may be a game changer, so to speak, for a lot of applications within ENT and head and neck surgery.
Nice. Dr. Roby, what do you see as the next step in this evolution of these models?
I think, number one, I think expanding the types of models that are available. We've really focused on what at least for our boot camp, it was what are the procedures that our fellows didn't always get as much exposure to, and then we expanded it to more of that global infrastructure. I think going forward, it's going to be looking at specifically being able to come up with real life models very quickly. And I think that's where the technology is going to come into play, because, for instance, if a certain part of the world has a high incidence for a specific procedure, whether it's temporal bone drilling, whether it's cleft lip repair, whether it's removing a specific type of head and neck tumor, being able to very quickly, if you're expanding and doing some education in a specific part of the world that just has a high need, being able to make a 3D printed model very quickly and cheaply so that you can get that into their hands and do the teaching in a very ready fashion, I think is where the technology is going to go. And I do see it happening, honestly, faster than I would have thought a few years ago, because it's just becoming so easy, and 3D printing is becoming much more readily available, even globally. again, the printers are cheaper and have much better material. So I see this developing very quickly, but really being able to come up with a real life model that can be printed very quickly and adjusting it to whatever the current situation is needed is where the technology has to go.
Excellent. Dr.
And
Sebelik,
Dr. Roby,
yeah.
sorry, I was going to just make a comment, Dr. Roby. I really like your model of making the trainer and sending it and sharing it. I think that's a really important transitional step to disseminating it, is creating it in one place, but then also share the instructions so that your recipients can become the teachers with their own models. So sorry for jumping in.
No, I think that's a really great point. And I think, I think it's finding the partners, right? It's finding the partners across the globe that have an interest in doing this, because what we have found with our simulation boot camp, again, is it doesn't take very long. Our boot camps are 4 hours. And by the end of that, you're really, it was funny, Dr. Peer made a comment about how after the last boot camp, one of her former fellows got up and said to her, they do it just like we do it. I mean, it was like a surprise to them that like we are teaching them and working with them to make sure they do the technique just like we would do it here. And I think that it's really important to highlight that, to emphasize with them that we're not teaching them anything different. They are learning the technique, and globally the type of surgical procedure can be done, and teaching them around the world. I think it's a realization to them that they have the skills and the ability, and it's just getting in the right educational scenario where we can get that information to them quickly.
Excellent. Well, let's shift and talk a little bit about the thyroid ultrasound simulation. I got to tell you, I very much enjoyed the videos, particularly the dramatic narration of the one was I thought I was watching a movie trailer. It was wonderful. Tell us a little bit about the evolution of that, Dr. Sebelik.
Well, thank you for noticing that, and that's actually a really good illustration of the transition we've made in thyroid and parathyroid and neck ultrasound education. Point of care ultrasound for the head and neck for surgeons has been around for a long time, and we've been teaching it in the United States for a long time. Our European colleagues are ahead of us in point of care ultrasound, but in transmitting any new skill, we actually have to identify our learners who are eager to learn, and then transition our learners into teachers. And that process is something called linkage. So we create students, we create colleagues, we create future teachers. So in 2011, Doctors Capuz and Luna actually came to one of the American Academy of Otolaryngology head and neck ultrasound courses. And Dr. Lisa Orloff and the two of them, the four of us, became friends. And very rapidly, the two of them, who are in training originally and then in practice in Manila, started becoming the Philippine version of ultrasound teachers and champions, and have taken not only the teaching of head and neck ultrasound anatomy and pathology, but the teaching of head and neck ultrasound interventions to a level that has probably surpassed what we can do here in the United States. So I will also admit that their ability to make education videos far surpasses anything I can do. They're amazing. But I will tell you, I've learned so much about creation of simulation models just by having the honor of working with my friends and colleagues who have really taken this to the next step. The issue is, for head and neck ultrasound, we can practice on each other. Each other and our patients with pathology are the perfect simulators. But when we're having to learn how to do interventions, we can't do that to each other or to a patient before we know how to do it well. So the industry of thyroid phantoms has been around a while. And the commercially available head and neck or thyroid appropriate ultrasound phantoms It has been there, but those models are very expensive and ironically have the same finite lifespan as something you could make in your kitchen or your basement. So whether you're in the United States or in Cape Town or in Manila, the motivation is the same, is to find a cheap, readily creatable, and reasonably realistic on several levels phantom so that you can learn how to do interventions. So I have to applaud my my colleagues for coming up with it, but we've all been doing this. We've all been making gelatin phantoms in our basements and kitchens. We've all been trying to figure this out. We've all been learning that balloons filled with water pop when you put them in hot Jello, and it's been a wonderful, fun 10 to 15-year process trying to come up with these. So I am so delighted to learn from my colleagues who do it so well.
And it's fun to watch the videos. It reminds you of something you saw at a potluck when you were a child, where there's fruit suspended in these. But what I thought was particularly clever was the variety of different things they were putting in the gel to try to simulate different lesions. The chocolate with the nuts versus the fruits versus the olives versus the creativity is really impressive.
And when you have a lot of time on your hands, you can test all the different foods. I have found that those little cooked potatoes that come in a can look exactly like a parathyroid adenoma. Who knew?
So, what are some of, as you've developed this in your own practice and your colleagues, what are some of the challenges in terms of fidelity that you've run into? Obviously you need a gel or an auger that's opaque, so you can't cheat. And what are some of the other things that you guys have innovated as you've developed this model?
I think number one is ultrasound fidelity. So whatever you're looking at with your ultrasound has to look somewhat similar to a target you might be seeing in a patient. Number two is the haptic feedback is important. So whether it's high concentrated food grade gelatin or a material called ballistic gel, which is great because you can melt it and reuse it, or food such as an uncooked chicken breast, these have to reproduce the feel of putting an ultrasound on the surface and finding a target and sticking a needle through it. Many simulation labs don't allow biologics such as chicken breast for cleanliness purposes, and even embedded olives and pearl onions and potatoes and things like that are still food grade. So there is depending upon what environment you're teaching in, you have to respect the rules and regulations there. I really much more enjoy teaching with food than with some of the more complicated models.
Dr. Roby and Dr. Basura, are your institutions doing anything similar in terms of ultrasound?
We haven't done this, with something, what I would say, so easily universal with this type of material. I feel like this is going to be my job, is just like Dr. Sebelik is teaching those around the world. I feel like I may have to bring this into my institution to incorporate this. It seems so easy and fun. I was in awe watching the videos. So we do work with the residents to learn ultrasound for thyroid and parathyroid, and I feel like it is more often they're actually learning with the pathology and not getting a lot of practice in a simulation setting. So I'm excited to incorporate this into kind of what we're doing with our institutions, and learned a lot from watching the videos, which tells you how universal this is, the technique that you guys have developed. If I'm thinking I can incorporate this here, just a couple states away, this is really a great phenomenon to learn.
Yeah, I agree. I think it's fantastic, Mary, what you're doing and your colleagues. I think we've had some limited exposure to this at University of Michigan, but I think largely that's because I'm at one of the institutions where
a lot of thyroid and endocrine surgery is done by an endocrine surgery department. And so they do a lot of the heavy lifting with a lot of that. And so we've been sort of adjunctively working with them, obviously for the resident training. But I think this speaks to the application of it even within home institutions, kind of like what Bree's talking about in a way, is that, a way to introduce it even within an institution like here in the developed world, so to speak, where you might be able to educate your own colleagues there to improve diagnostic capabilities in limited resourced areas. So yeah, I think it speaks to the application of it, and hopefully it can continue it in all sectors regardless of the stage of the training.
I was particularly impressed, Dr. Sebelik, with the cyst that they created with the chicken breast, and were able to, practice aspirating and instilling ethanol, and my own partners do a gel simulation with the residents, but I don't think they've ever thought of that. That's I'm going to show them that video as soon as we have a chance here, because this is very clever. All of you, talk to us a little bit about how do we leverage relationships with our biomedical engineers to develop these technologies for simulation. Now, not all of us have the benefit of having a child that is in this field, but clearly Dr. Roby has a colleague that's got straddles both sides of the fence. How have you all worked with your colleagues to develop these ideas?
Well, I think I'm going to have to follow Mary's footsteps and try to get my children to follow careers in biomedical engineering. So I've got a few years to put some pressure on them. What I think is really great is at a lot of institutions, simulation labs have really come into the forefront of education. Now, more often they're doing things like practicing running a code, right? Or, helping teams develop those kind of models. But I think if you sit down with the simulation labs at many of the institutions, the cool thing about it is you've got people there who are excited about different opportunities. They want to sit down with someone who has some ideas and brainstorm. And so I think what really is, I think there's two parts to this question. I think the first one is finding partnerships if you're at an institution or in a city that's got some sort of simulation lab, and sitting down with the people who run it and getting ideas of what all opportunities there might be and what are things that they might be wanting to expand. An example, we set up an emergency airway cart, and we wanted to really practice on speeding things up for doing neonatal emergency airway stuff. And it just took a couple of meetings to sit down and be like, how do we make this so that suddenly a button gets pushed and the charge nurse and the NICU is doing this, and the surgeon is running and the neonatologist, and it just took some brainstorming with that kind of a simulation. And so when I think about 3D models or other sorts of surgical technique with simulation, I think what it involves is sitting down with them and saying, I want to teach this type of procedure. And there you might throw back some ideas and you're like, that doesn't really seem to work. But what about this? And all of a sudden you've got people who are enthused. That's the thing about simulation, is almost everyone involved in simulation labs at universities, they're super enthusiastic, and they are like just itching to expand what kind of uses can have it. I think if you can develop a technique at your university, then you also will be able to say, well, how do I take this globally? So I think that's the first thing. And then the second thing, I alluded to it a while ago, but you really have to work to partner with your global colleagues, right? And when you're forming those partnerships for global education, it doesn't matter if I have a cool simulator on how to do cleft lip repair. If they're doing, 1 million cleft lips a year in their country, they don't need me to give them a cool simulator on cleft lip, even if I think it's really cool. they might need something more on how to do thyroid ultrasound and do a needle biopsy. They might need something with temporal bones. And so I think it really, as with all global education, involves you sitting down with your global partners and not saying, well, I have this opportunity, but more coming to the table and saying, what opportunities do you guys need? And then brainstorming how to develop that type of a simulation model.
Yeah, I agree, wholeheartedly agree with that. Especially your second point. I think the key is to adapt the technology around the needs in the country or the location you're trying to help. Because I think so often we think about our own agendas, and you got to be careful about going into a place with a preset idea about what you're going to achieve there. You have to go in and do a needs assessment. Think about not only what are their needs, but how can you best meet the needs? And then you almost have to reverse engineer all this stuff around that to meet the capacity and the need there. So you have to be very thoughtful about this stuff. I don't think it's a one size fits all thing. So I think, and I also think too, when we talk about, if you think about surgical simulation in the same vein or same, sort of thinking as like medical and surgical equipment, we got to be thinking very simply, because if you take a big high price thing over there and it breaks down and no one can service it, it's kind of useless or worthless or burdensome. And so you want to be very simple in your thinking. And if something were to break down or malfunction, how can it be resurrected so that it's actually still useful? So you got to be very careful about the level of the engineering and how applicable it is.
Well, I agree. I think cost is critical no matter where you're teaching or learning. Here in the United States, our otolaryngology departments don't have money for high expense, highly sophisticated models or even equipment. I was happy to see, and when I've been teaching in the Philippines, I was going to show you this. Whoops, can I do it in the camera? So one of the things that's accelerated ultrasound training around the world is the dramatic reduction in price of handheld, very simple ultrasound transducers. And you'll notice that in Manila or in Atlanta, Georgia, we're using basically the same, I can't get my camera to show it to you. There we go. So you can plug that into a cell phone. And the industry abounds with these low cost handheld transducers. And guess what? Everybody has, no matter where you live in the world, a cell phone. And so I think what all of you are saying is that the motivation to reduce cost is equally as critical here in Atlanta, Georgia, where we don't have money for fancy things, as it is in Cape Town or Manila. So I think it's really important. The industry is helping by bringing down the cost in some things, but our creativity and collaboration is also moving this along.
Absolutely. So I know we've kind of just touched on it a little bit, but briefly, where do you guys see areas of growth in otolaryngology surgical simulation in the near future? And it may not necessarily be in your unique area of expertise, but where's the low-hanging fruit? Where's the soft spot? Where are we going next?
I can jump in on that. Live remote education. Do we need to fly somewhere to educate? Or can we leverage all the things we learned during the pandemic about meetings like this? I think that is the next step. Do we need to be flying? Do we need to fly learners to big, expensive meetings with hotel bills and registration fees? I think we should and can rapidly get better at remote collaboration.
100% agree. I think that's been the real fun with the boot camp that we've done, is actually being able to demonstrate that you don't have to be, you can be, in the same location, you can be a world apart and still find an easy way to plan an educational simulation. And I think harnessing it, again, I think the pandemic expedited all of this. For all of the downsides, I really do think it lit a fire for us thinking about ways we could expand simulation. And I think all of these models that everybody has talked about today, I see trying to expand that and making sure you're reaching out to other parts that are desperately in need to train and demonstrating ways that they can do it easily. So I'm excited for where this is going.
Yeah, I agree completely. I think simulation labs, telemedicine, I think at some point, maybe even private companies might catch wind as to the value of maybe sponsoring or building low-cost simulators, pieces of equipment that can be used in humanitarian outreach. So it may just become part of a new arsenal for medical companies, bioengineering companies, medical tech companies that might help promote their own indirect use of their instrumentation by facilitating practice to get to that point. So I think it's wide open. I think it'll continue to be a premium, particularly simply from a cost issue.
Yeah, absolutely. And, the future is going to be one of collaboration. And, they say that necessity is the mother of invention, right? And so with whatever needs you have in your particular situation, the resources that you have, we need to be vocal about that and share those with one another, because it's the collaboration that leads to these new developments. And as you can see from each of the 3 simulations that we've looked at today, these are global cooperations that have made these happen. And so wherever you are watching this webinar, if you've got an idea, speak up and share that, and let's collaborate together to improve surgical education for everyone everywhere. So I think we will wrap that up for now, and we look forward to further webinars from the Humanitarian Efforts Committee, and hope you'll join us. We would appreciate any feedback that those of you watching have to share with us, and we wish you the best in your adventure with surgical simulation. Thanks again for joining us.